Hello, my name is Michelle Morand. I am a precision cancer medicine educator and patient advocate. And for the last 14 years, I've been helping cancer patients access the most effective therapies for them, independent of whatever their standard of care oncologist is prescribing, and usually with the support of their standard of care oncologist. Why I'm here today is to just introduce a video that the cancer guy Alexander Rolland made with me very recently to talk about resistance mechanisms. So many patients are having to get a rapid PhD in the use of genetics and new types of therapies to inform their care. And resistance mechanisms is something that many patients and doctors just don't understand. So what this video is going to do is it's going to tell you all about what a resistance mechanism is, how it affects your therapy, and how you can tell if you have one, and how you can make sure that your doctor doesn't take you off a therapy that's working well, and gets you on the therapy that you need most. So watch this short video from Alexander Rolland, learn all about resistance mechanisms, and then if you'd like our help with your testing or with advocating for care with your oncologist, let me know.
So resistance mechanisms can be genes that are stuck turned on, or they can be genes that are overexpressed, or they can be fusion genes, which changes, the function of the gene, or can also just cause overexpression of the gene. You have to look at the specific resistance mechanism. And, I see this all the time, is where doctors will just blindly give drugs to patients, hoping, that is going to work without actually even doing tumor DNA sequencing or RNA expression testing and not understanding the mechanisms. And that's one of the biggest problems, is the application of these drugs. Doctors should not be tasked with trying to figure out what the resistance mechanism is. That's not their training. That's not their job. Their job is large enough in keeping a patient alive and supervising them. Literally, we need a whole new discipline here to be able to educate and tell the doctors, here is a resistance mechanism. This is the drug that this patient needs versus your other patient who has a completely different resistance mechanism and needs a completely different set of drugs.
So how is that determined though? Like, if the oncologist were to get some data from somebody saying, here's your patient's resistance mechanisms, what would that person have done to get that data?
So the different tools that we use in this day and age are the tools that we've used in developing these drugs. Okay. They are the lab-based tools such as tumor DNA sequencing, which is taking the DNA of the tumor and finding out what the resistance, or finding what mechanisms are causing the problem. Okay. We now have a great tool for identifying resistance DNA mechanisms, DNA based on DNA mutations, called liquid biopsies. And so we can actually look for key mutations. So we actually, when we first started dealing with this, we developed a liquid biopsy to detect the EGFR T790M mutation. We also developed a liquid biopsy to detect MET amplification, because those are the two main mechanisms. So as soon as a patient became resistant to the first line, second line treatments of the EGFR inhibitors, we would use these liquid biopsies and find out exactly what the resistant mechanism was. Mm-hmm. Now we have, there's many companies doing multi-gene liquid biopsies. Now, the thing is with liquid biopsies, and one of the problems I see occur quite a bit with these, is they are good for detecting resistance mechanisms. But if your cancer is not progressing, then you're not going to have very much tumor DNA in the blood. And that's part of the problem. So it has to be in the process of resistance in order to detect the resistance mechanism. Otherwise, you'll just be spending money on a test that gets you nothing. Okay. Also, we have developed a blood-based exosome-derived liquid biopsy that looks at RNA overexpression relative to specific tissues. So we can now take a sample of blood and we can see what those driving mechanisms are, which genes are overexpressed. And so a mutation doesn't always cause overexpression. It can cause the gene to stay stuck turned on, and then you'll see overexpression of the downstream signaling, but not that specific gene, or it can cause, overexpression. And so having this panel of just under 21,000 genes that we can use to determine overexpression is a real game changer for us.
Mm-hmm.
It really adds another tool. And these resistance mechanism detection tools are advancing all the time.
Yeah.
But the best way, obviously, is if you have a new tumor occur, then you want to get a biopsy. There's nothing better than that. Because then you can get that biopsy. You can say, okay, here's what's driving this new tumor. And, one of the common problems I see in cancer treatment this day and age, it's a real issue, is if a patient has a new tumor occur while on treatment, the doctors will shut down the treatment and say, okay, your treatment's not working anymore. We're canceling these drugs. When most of the time, it's just a breakaway tumor. In other words, the drug combination is controlling the vast majority of the tumors, but you have this one resistant tumor.
Yeah.
So instead of stopping the treatment altogether, what needs to happen is you need to target that specific tumor directly. And you could do that through radiation therapy in many cases. You could do it through surgery. You don't need to throw out the baby with the bathwater, so to speak. And
Yeah.
so often when patients get a breakaway tumor, the doctors will stop everything. And then all of a sudden the patient has tumors all over their body because the ones that were being continually repressed by the treatment are no longer being repressed. I see this all the time, and it is a lack of understanding of cancer and its mechanisms. And the problem is medical doctors don't typically have the understanding. They don't have the expanded knowledge of cancer mechanisms and drug resistance mechanisms that somebody who only studies that does.
As a
And
patient
so this is where this discipline is missing.
Yes, and even worse, the administrators at the various federal, provincial, state, national, wherever you're living, cancer agencies, or the people who determine from a healthcare perspective for your state or province or country what will get covered, they don't understand this.
Not at all.
So I deal with it all the time in my role as an advocate, where because a patient progressed on treatment X, even when we can show the doctor why they progressed and how, keep them on this and add this, even if the doctor wants to write that prescription and wants and works to understand this, the administration who has to say, yes, okay, the patient can try this again, or we understand this was working and we just needed to add this, not take them off. It's practically impossible to get the people in those situations who ultimately have to approve the therapy to do so, because they just say, no, you've already had it and you progress, therefore, no, you can never have it again. And that doesn't mean that we can't help you get access to that drug, just so you know, but it does mean there's a lot of barriers and hoops, and you may have to pay out of pocket when you
Yeah.
really shouldn't.
What's really sad about the whole thing in cancer treatment in this day and age, and this is common, this is a human frailty, as far as I'm concerned, because I see this in many different disciplines, is it's an admin problem. It's not a we don't have a drug for your cancer issue. It is a completely a logistical admin problem.
Yeah, that's right. Yeah, absolutely. And so really the fundamental point of this little sidebar about resistance mechanisms common across all types of cancers.
Mhm.
There are tests. Alex was talking about tumor DNA testing, which you must have for sure. At least 350 genes, ideally 550 plus.
Yeah.
And then this blood-based RNA test, this test that looks at every gene in your body, 20,813 of them that we know about,
Yeah.
using that test to stay on top of any emerging mutations, to see what is now driving the bus. Because what Alex was saying is a very subtle point. Just because your tumor DNA test shows that you have a certain mutation, that does not mean that mutation is involved in your cancer. It does not mean, especially most important, it does not mean that that particular mutation is currently a primary driver of your cancer. And most oncologists don't understand this distinction, and they don't have the tools to be able to figure out which is what you need the RNA expression test to do that. So oftentimes they will simply prescribe the one that showed up at the top of the list that they know of. And then when that doesn't work, as we've been talking about, because you may have had other mutations that were really primary drivers, or now you've developed a sensitivity to this, they're out of options, when in fact there are so many more options that can buy you many more years of quality life. Thanks, Alex. I really appreciate that. I think that extra little bit about understanding that and what to do about it to kind of get ahead of it. You don't want to wait until your treatment isn't working, essentially. You want to know what you're going to do next. And that combination of the DNA and the RNA testing is what gives you that information.
Yeah,
And then
totally.
ongoing monitoring with a blood-based RNA test is what makes sure you stay well ahead of emerging mutations and you're always on the right therapy. And that's what I want to say to you at home who are wondering, how do I apply this? How do I make sense of this? How do I make sure I'm always on the right therapy? That's how.